We're sort of going back to basics to understand some of the things that we read about a long time ago and try and apply what we have read to our current scenario. So what I'll try and do in the next 10 minutes or so is actually speak a bit about the corneal stroma and the Descemets membrane. Obviously, I'm not going to be able to cover all of this in 10 minutes. But what I will do is I will avoid speaking about the normal anatomy because all of you probably are already aware of that, but focus more on the structure of the stroma and how it actually affects surgical outcomes, with more focus on the posterior stroma and the pre-Descemets layer, which is the area of our focus now, and about the Descemets membrane as well from the perspective of surgery. Now, remember that all of these are from the perspective of pre-op considerations, intra-op as well as post-op considerations, and would apply to all kinds of endothelial keratoplasty and are not just limited to DMEC, but would apply to other surgeries like DSEC as well. So the corneal stroma, very basically, all of you know, has three major components. There's several other components, but we won't talk about that in detail. The structure of the stroma is derived from the collagen fibrils. The cells in the stroma are predominantly from the keratocytes, and the extracellular matrix is predominantly the proteoglycans, or the glycosaminoglycans that we'll look at a little more in detail later on. Well, all these structures are organized in a sort of a meshwork. They're not separate, and they're all interwoven in a meshwork, which is probably impossible for us to replicate as an artificial structure. And interestingly, if you look at the stroma from the point of view of the different layers or the levels from which the stroma is sourced, and this is mainly to compare how the anterior stroma is different from the posterior stroma. In this very interesting electron microscopic study, where the corneal lamellae that are distributed within the stroma were studied to look at their organization in different parts. Now, remember that 70% of the dry mass of the cornea is collagen. And so these lamellae or these fibrils that you see here are basically made up of collagen. So the structure of arrangement of these lamellae are basically bands of fibrils that are bound together, is different in different parts of the corneal stroma. And if we look at the anterior part of the corneal stroma, the lamellae of the cornea tend to interdigitate quite a bit. That is, they tend to actually cross each other's path from forward to posteriorly, and some of them even angulate to the extent of 90 degrees, that is, they pass almost vertically forward. The mid-stroma, this tends to come down a little bit, and the stromal lamellae are more parallel to each other, and they become most parallel with the angulation between the stromal lamellae, the least in the posterior stroma. Now, what are the implications of all of this? We'll come to that in a minute. But also what is interesting is I would encourage all of you, and we'll send you these resources, to read the article about an architecture of corneal stroma, a lovely editorial by Anthony Braun. This is from 2001, but very relevant right now as well. And again, this article present in the same, published in the same issue of the British Journal of Ophthalmology, which speaks about the specific architecture of the different parts of the stroma, clearly shows that as you swell corneas artificially, the anterior stroma remains relatively unchanged. And it is the posterior stroma that actually tends to swell the most from the point of view of artificial development of corneal edema. Now, this is again very interesting because if you look at the development of corneal edema, you will actually see that corneal edema tends to develop most often in the posterior stroma first, if you observe it carefully, and then moves on to the anterior stroma. And also in this article, they realize that if you look at the anterior stroma, which is the white circles right here, even with significant duration of hydration, there was no significant thickness in the anterior stroma, whereas the posterior stroma continued to swell. So when you're looking at a patient who has corneal edema, the anterior 120 microns of the corneal stroma probably does not swell. And it's the rest of the corneal stroma that is contributing to the increase in the thickness of the cornea as you're evaluating that patient. The other important aspect of the arrangement of collagen fibrils within these lamellae is the optical properties. Again, we're not going to go back to school to talk about the spacing and why it is important for this spacing to be regular. But what is also important is the fact that if you do X-ray diffraction studies, again, this is from Kenneth Meek and his group, fantastic studies about X-ray diffraction. which tell us a little bit about the organization of corneal fibrils and lamellae within the cornea. You see that they're actually interwoven and they're actually interdigitating around the limbus, and they interdigitate less as you come to the center of the cornea. Potentially why you probably see weaknesses of the cornea like keratoconus occur in the center, but not towards the periphery. But what is also interesting, if you look at the transmission characteristics of the cornea at different depths from anterior to the posterior stroma, you will actually see that the anterior stroma tends to have more reflectance as compared to the posterior stroma. And this is again is confirmed by this lovely article from Edelhauser, where they looked at the differential scattering properties of the anterior and the posterior stroma. And they found that the anterior stroma actually tends to scatter more light as compared to the posterior stroma. And also the transmissibility of light of the posterior stroma is much better than the anterior stroma. What this article really says is if you divide the stroma into anterior and posterior, optically the posterior stroma actually is clearer than the anterior stroma. And from the previous article, we learned that the anterior stroma is what really provides strength to the cornea, whereas the posterior stroma probably does not provide as much strength, but actually adds clarity to the entire optical properties of the cornea. And interestingly, and we will have this discussion later on, is about when to intervene when you have a patient with corneal edema. It is reminiscent of what we read in our ophthalmology, that a change in the distance between the corneal fibrils because of swelling, as you see in the picture below, will actually retard the light transmissibility through the cornea. And this is interesting because hydration of corneal edema not only changes the transmission characteristics of light, but it also does this differently for different wavelengths of light. In fact, it affects blue light much more than red light, and it also causes a lot of scatter, which is something that we really do not measure in the clinic. And so if a patient is complaining of visual phenomena that we measure visual acuity, it might not be the best measure of making a decision about surgery. The other interesting aspect is as the cornea gets more and more hydrated, the refractive index of the cornea also reduces. So it's not just a change in the transmissibility of light, but also a change in the optical properties from the point of view of how light is refracted when it goes inside the eye. So there probably is a change in the refractive error as well. So what are the implications of what we just spoke about? Number one is the fact that the separation of corneal lamellae in the posterior cornea is different from in the anterior cornea. And because of that, you probably will be able to dissect the posterior corneal lamellae, which is something that we all know much more easily. And this is the origin of lamellar corneal surgery. And this is the reason why dissection in the posterior stroma, like in DSEC surgery, is much more easy than dissection in the anterior stroma, like doing for an ALK. Also, when you're looking at corneal edema, you see that because of the separation of the lamellae, the corneal edema tends to aggregate within the lamellae or between the lamellae. And so there is separation of lamellae and there's an increased anterior posterior thickness, but there is no increase in the diameter or there's no stretching of the cornea laterally because that is not how the lamellae are arranged. And also edema, like we spoke about a little earlier, is more evident posteriorly than anteriorly earlier in the course of the disease. Additionally, whenever you have corneal edema, because most of the thickening occurs in the posterior stroma, there is a minimal change in the curvature of the anterior stroma. Otherwise, you would have a lot of bumps on the cornea if you have had corneal edema with the same structure in the anterior and the posterior stroma. Also, early edema tends to cause light scattering and also changes the optical properties of vision, which probably might be evident more for the patient than for us because we do not measure these in our routine clinical practice. Now let's move on to the kind of collagen that is present in the cornea. Collagen is part of every structure or tissue in the human body, and a lot of our tissues actually do have collagen. And there are different kinds of collagen in different types of tissues. Mainly the type 1 collagen, which forms the bulk of the cornea, actually is present in a number of other tissues in the body. Whereas type 4 collagen is typically the collagen that is deposited in the basement membrane in various tissues in the body as well. And this is a similar kind of collagen that you will find in the Descemets membrane too. What is interesting is if you go back and read about the different kinds of collagen in the body, the kinds of collagen also tends to organize themselves in different ways. So you have the type 1, 2, 3, 5, and 9 collagen, which tend to form lamellae or structures that tend to interdigitate, very similar to connective tissue elsewhere in the body, like ligaments and tendons and other parts of the body, and also very similar to the corneal stroma. Whereas type 4 collagen generally tends to form sheets because this forms a basement membrane on which cells tend to grow. And so the kind of collagen is also determined by the requirement and the kind of function that they have. Now, the corneal stroma, as we discussed so far, the anterior as well as the posterior stroma arrangement is also important from the point of view of creating dissect tissues. Earlier, surgeons tried to use the femtosecond laser to actually dissect the posterior cornea to create dissect lenticules. But what they found was as they tried to do this, the cornea tended to become very irregular in the posterior stroma just because of the arrangement of the stromal lamellae and also because of the fact that the posterior stroma tends to accumulate more fluid. So the femtosecond energy seems to be getting dissipated in the posterior stroma as compared to the anterior stroma. And compared to a microkeratome, as you see here in the bottom right, the bed or the stromal bed was not as clear and smooth as when dissected with a microkeratome. This was corroborated clinically as well when various studies, at least 3 publications are available, where lenticules that are created using the femtosecond laser tend to induce more stromal scarring as compared to those lenticules that are created using the microkeratome. And the microkeratome lenticules also tended to result in better visual acuity as compared to those created using the femtosecond laser. The other component of the corneal stroma that we spoke about is the keratocytes. So these are not the only cells in the cornea, but these are the cells that are in the closest proximity to all the action that is happening in the cornea. In the anterior stroma, the keratocytes again are much denser. These are the nuclei that you see on confocal microscopy. The posterior stroma, they're not as dense. And so the total volume or quantity of keratocytes in the posterior stroma is less than in the anterior stroma. They also tend to get activated less commonly than in the anterior stroma. And this is probably the reason why when you do dissect surgery and you actually attach or appose stroma to stroma, the interface does not scar as much as you would get when you have an interface in the anterior stroma. And this is again correlated to the fact that you don't have fibroblastic transformation of keratocytes as commonly in the posterior stroma, one because of volume, and also secondly because of the fact that they don't tend to get activated as much. And that's probably the reason why whatever interface haze you get in dissect surgery is very limited, and it tends to come down quite significantly with time as well. The other interesting part of the cornea is the extracellular matrix and the glycosaminoglycans. Now, you also would know that the chief glycosaminoglycan in the cornea actually is keratin sulfate and is present majorly in the corneal stroma, whereas the other glycosaminoglycans are distributed in the extracellular matrix of the posterior part of the cornea, as well as other cellular components of the cornea, like in the keratocytes and also in the endothelium. Now, what is interesting to see the fact that if you store corneas in various preservation media, especially organ culture and in media that contain dextran, the percentage of these glycosaminoglycans actually tends to go down in these media. And so it also alters the glycosaminoglycan concentration. And so the swelling characteristics also tend to change. So your plans will also have to change depending on the duration that you store a tissue in these media. Now, in addition to these glycosaminoglycans, there are several extracellular matrix components within the corneal stroma, and several of these are also inflammatory components. And you also see that there are several publications that talk about alterations in the extracellular matrix and also activation of various inflammatory mediators within the extracellular matrix in patients who have bullous keratopathy. So in effect, bullous keratopathy is not just alteration of the corneal swelling and accumulation of fluid, but also seems to be a micro-inflammatory response to whatever changes are happening because of the inflammation and also because of the accumulation of fluid. Now, coming to the posterior corneal stroma, this is a famous article from Professor Dua that spoke about the presence of Dua's layer and the Descemets membrane as 2 distinct layers. And you can see from his EM studies that the Descemets membrane and the Dua's layer have been shown as 2 distinct layers that can be distinguished or are held together with fibrils, as you can see in figure D. But these are attached very firmly at about 8 or 8.5 millimeter diameter of the cornea and do not extend right up to the periphery. Another article about a couple of years after Dua published his the evidence of the Dua's layer, again from a number of ophthalmologists, again tended to disprove the fact that a pre-Descemets layer or a Dua's layer does exist. And they actually base this on the variable thickness of this pre-Descemets layer in different parts of the cornea. But then again, this actually proves that there might be a pre-Descemets layer, except that it is variable in different parts of the cornea. And this is evidence from several surgeries. This is an example from a patient to whom we're doing DALC. And if you can actually see the OCT of this patient with the bubble between the Duas layer in front and the Descemets behind, you actually can see a clear demarcation or a clear separation between these two kind of layers. And you will also see that as the bubble is excised, incised, or the Duas layer is incised, as you can see here that I'm doing, the bubble escapes, and you can see the Descemets membrane bounces back. Again, evidence about two anatomically as well as functionally separate layers within the corneal stroma. Why is this important? Because if you correlate this to DMEC versus PDEC, PDEC is supposed to be an alternative surgery to DMEC, where you transplant not just the Descemets membrane, but also the Duas layer. The fact that because the Duas layer is adherent to the cornea at about 8 to 8.5 millimeters zone diameter, limits the size of your PDEC graft that you can put inside the eye. And though PDEC does result in good visual outcomes, you are limited by the potential number of endothelial cells that you can transplant inside the eye. So Dipender also spoke about the ultrastructure of the Descemets membrane, the anterior banded and the posterior non-banded zones. What is important to also remember is that the posterior non-banded zone tends to be variable in thickness. So this thickness continues to increase throughout life. And in an older patient, you will have typically a thicker Descemets membrane, which also is easier to strip during surgery as compared to a younger patient where the adhesions are greater, like Dipender mentioned, and is also more difficult to strip because the thickness is quite low, can be as low as 4 microns in thickness. Also, the Descemets membrane removal by itself seemed to have its own side effects. And again, a fantastic review article by Steve Wilson, who speaks about the effect of removing the Descemets membrane on the residual corneal stroma. And he hypothesizes that once you remove the Descemets membrane, it sets into effect an arcade of events which leads to the deposition of several inflammatory mediators and also activates fibroblasts from the limbus as well from the aqueous. And because of this, you tend to have more scarring or more deposition of extracellular matrix in the posterior part of the cornea that is denuded of Descemets membrane. And for this reason, he says that it's very important to preserve as much Descemets membrane as possible because regeneration of Descemets membrane is not easy and does take quite some time. Lastly, let's just talk about the effect of the Descemets membrane and the effect of various stains in the Descemets membrane. Different people have used different kinds of stains from brilliant blue to ICG to trypan blue, but trypan blue seems to consistently stain the Descemets membrane very effectively. But what does the stain do? If you have unstained Descemets membrane, the elasticity is usually better. But if you stain the Descemets membrane with trypan blue, the Descemets become more rigid and it also becomes less elastic. So it tends to tear more easily and it also tends to form a scroll less easily. So if you want a Descemets membrane to behave in a manner that it doesn't scroll too much, then staining with a little extra with trypan blue generally will help during surgery. So to sort of summarize this back and forth anatomical clinical correlation, just the fact that a few take-home points, the structure of the organization of the collagen in the stroma will determine where you get your corneal edema. And that's the reason why corneal edema tends to be maximum in the posterior stroma as compared to the anterior stroma. Disorganization of the structure of the lamellae can lead to early visual effects because of scattering of light, not just because of retardation of transmission of light in the eye. The glycosaminoglycan distribution also affects fluid distribution in the stroma, and this is why you have more fluid in the posterior stroma and also tends to remain in the posterior stroma longer. When you're trying to do dissection of the posterior stroma, this is easier because of the organization of the lamellae, and so it allows you to do dissection more easily. DMEC allows you to do larger grafts and put in more endothelial cells than PDEC because of the anatomical challenges that occur with the pre-Descemets layer. And with age, the Descemets membrane thickens and also becomes stiffer. And especially if you stain it with trypan blue, it tends to become less malleable and more rigid with time. Thank you very much.